increasing age, more of the embryos may be abnormal because of the older egg DNA. This applies if there's an older male partner as well.
Hello everyone, it's Catherine Chong here. Welcome to another episode of our YouTube fertility channel. If this is the first time you're joining us, don't forget to press the subscribe button and also to follow us on our Instagram at catherine.fertilitydietitian. Now I'm super excited today because we have a very special guest, Dr. Neil Astill, joining us today to have a chat about how you can prepare your body the best for embryo implantation for IVF treatment. All right, thank you so much, Dr. Astill, for joining our interview today. Now, I'm really curious to know, Dr. Astill, what makes you so fascinated about, getting into reproductive medicine and decided to specialize in fertility and IVF?
Well, it's a convoluted course, as you could imagine, of events. Catherine, I started off early in my career, I was in general practice and then anaesthetics. I did for a couple of years. And I happened to work in a place where I was actually the anaesthetist. That was a very big and very exciting obstetric unit. And so primarily early on, I was mainly delivering babies, and it became apparent to me as I drifted along through time that there was a number of women who had a lot of trouble getting on that pregnant journey. And that created some interest. So then for a number of years, I stayed with my focus on obstetrics, but I quietly got more and more involved with the fertility aspect and soon began to realize, of course, it's a very stressful journey for many, and pregnancy not to be taken for granted. So it was the human side. The science side is fascinating. It's a whole world in itself. And that's what encouraged me, and also see the joy that so many young couples get when they finally crack the jackpot, as I call it, and become pregnant. So it was not a direct line. It wasn't what I anticipated, but I'm very happy that I ended up in that journey.
That's good. I think we all do, to be able to see helping client going through that journey, trying to conceive up until they get pregnant and have a baby. That's fascinating me as well.
Yes. And the ones, there's so many people where it is such a difficult process, and it's a very human, stressful process for some, sadly.
That's right, Dr. Astill. So today we're going to discuss how men can best prepare for embryo implantation, and also have a chat about what is considered or defined as recurrent implantation failure.
Well, it's got to be remembered that the egg only lives for a day, and it's probably at its best the first 12 hours. So the best has to be made of that opportunity, short-lived, 24 hours. Now, most pregnancies occur with intercourse having taken place prior to the egg coming out, because within a day of it coming out, it's almost the opposite, natural family planning. You're not going to fall pregnant because the egg won't fertilize. So when the egg fertilizes in this window of opportunity of a day, it develops for 5 or 6 days as a young embryo before it implants. And that's what's called a blastocyst. That's just the formal scientific name given to an embryo at the time of implantation. The sperm survive for a lot longer in the uterus. They'll easily survive for 5 days, maybe 7. But the issue really is that short lifespan of the egg in terms of timing. Becomes a blastocyst over 5 days. The lining has to make the appropriate development in that week, being receptive for the embryo. And it's not an easy one to develop. There's a lot involved with implantation. There's inflammatory change, the immune system, new blood vessels have to develop. There's growth factors, stem cells, hormone receptors. So it's a very, very involved process that has to go right. And there's a little bit of uncertainty, how much the antioxidants and vitamins assist. But anything that is helpful or stimulatory to the immune system is probably a help, and that's where lifestyle and other factors start to really kick in.
And I guess that in the IVF context then, for client going through IVF, how would you define like implantation failure?
Well, generally in Australia, we regard it as three, if someone's having IVF, but 3 implantations in a row where pregnancy doesn't develop. In other words, you have the embryo, you know you've got that, so that last phase to be pregnant is the embryo digging in. If that happens 3 times in a row, negative, 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 we regard it as recurrent failure. With success rates getting better, a few clinics here and certainly some in the United States would regard even 2 in a row as being recurrent failure. But that's fairly demanding. If you're not, if a couple aren't having IVF, our species generally runs on about a 20% chance per cycle. It's called fecundity, and that's why overall it's thought, well, in 6 months, just by sheer statistical odds, you should be pregnant if you're trying. You know, you're getting a 20% every time in the cycle. And that's where recurrent implantation failure comes in with IVF. It's because, all right, success rates now are 35, 40% per embryo. So if you're not pregnant with 3 embryos being transferred in 3 separate cycles, then you think, well, you're getting out of that statistical range. You should be pregnant unless something a little bit unexpected is holding you back.
So I'm just curious to learn from you as well, because I say a lot of patients stuck in the same phase like this where they really try their 100% to improve their egg quality, but when they get into that transfer stage, unfortunately, it didn't succeed. So what are some of the common factors that can actually cause implantation failure?
Probably the commonest is the embryos aren't normal. And so, look, that could be 3 embryos in a row, or you could have a run again that are normal. So with increasing age, there are other things, but with increasing age, more of the embryos may be abnormal because the older egg DNA. This applies if there's an older male partner as well. For the female, it starts to reduce their statistical chances from 35, but particularly late 30s. For a male, it's more like 45 to 50, where, again, the DNA, the sperm DNA generally isn't quite as good. And so the older male can certainly be relevant as well. Or a male who's not in good health. Yeah, we tend to direct things towards the female. So the male's being neglected somewhat traditionally, but I think there's an increasing awareness now of how big and important a member of all this that he is. All right. So quality of the embryos is probably number 1. And the older the patient, the poorer the selection of embryos too. So a young woman will still produce some embryos. But with older women, one of the reasons that miscarriage rate goes up is their lining over time doesn't get quite as good at the selection process. So if you've got an embryo in a younger person with abnormal chromosomes, it's more likely to be rejected as such, not get pregnant in the first place. Negative pregnancy test, period comes. In the older female, they're a little bit more vulnerable to allow implantation of an embryo that's not going to really be viable. And that's where their increased miscarriage rate comes from, as well as other things with increasing age. So the selection is important as well by the lining. We're not sure how it does that, unfortunately. But certainly, I mean, medical problems are more common with older women as well. So fibroids can cause, they're gristly, like little lumps that you get in the uterus. That can cause miscarriages sometimes. They often don't, but they can. Again, they're more common as women get older. Polyps in the lining of the uterus, we know that if the lining is a bit over fleshy, forming a polyp, then we know that that is not as favourable an environment for implantation. So statistically, a little bit less chance of pregnancy. And there is an abnormal shape of the lining and the cavity. That doesn't relate to age, because that would be a shape that's been there all your life. And that's more associated with late miscarriages rather than not getting pregnant in the first place. Endometriosis is always there in the background for women, particularly women having trouble falling pregnant. And that can affect implantation as well as egg quality. So it's another big factor. Some of the medical problems, a thyroid disease, for instance, that's again with age, but anyone, there can be hypo or hyperthyroid that can affect egg quality and hence implantation somewhat. Diabetes, as you would see commonly in your practice, is a big factor. And lifestyle creeps in here with recurrent failures, because obesity is one of the major things that you would have to work with on a daily basis, and indeed we all do in medicine. And obesity can affect egg quality. It can affect sperm quality as well. So therefore, if the DNA is not as good, pregnancy rate again is going to go down, miscarriage rate up a little bit if pregnancy does occur. And I think a number of people aren't aware that obesity does those things to you. And it's not an all or nothing. Of course, people can be majorly overweight, as you know, and still fall pregnant and do very well. So we're talking of association and increased risk. So I think probably abnormal embryos would be the common thing, and general health lifestyle would be sitting up there pretty high as well, because of its impact, direct and indirect. And then abnormalities of the uterus itself, with endometriosis being in there.
Really, really good point. Thanks for sharing that, Dr. Esther. I guess that for the audience listening right now, they're like, whoa, it's quite a lot to take in as well. I mean, going through, the fertility journey, especially going through IVF as well. How, like in your practice, how do you help patients to break it down, make it this simplified way to help them to really, go through each stage of their journey to find out the possible cause and rule out one by one to help them to get there to maximize the chances.
Exactly. As you would do in a nutritional dietary practice as well. I mean, the most complicated one, I guess, to mention first, because chromosomes of the embryo are such a major thing. We can biopsy embryos to check their chromosomes, but obviously that means IVF. There's no soft way to do that. So you have to have the embryos, create them, biopsy them for their chromosomes, and then we freeze them. And we wait 3 weeks roughly for the result. And I'm just picking a number. Let's say you have produced 6 embryos. You could find 6, 5, 4, 3, 2, 1, 0 are actually normal. So you could inevitably be transferring embryos that look fine under the microscope, but are never going to get the couple there. So it gives you an idea of the proportion that are normal and abnormal, and because you only transfer the normal ones. So for IVF patients, we don't recommend biopsying just automatically as a routine, but it does probably give you the shortest distance between trying to fall pregnant, if there's a problem, and falling pregnant. It does bring that time frame down, because some of that time you could be transferring embryos that were never going to make it, unbeknown to your doctor and to everybody else, including the scientist, if you haven't biopsied them. But as I say, we don't do that as a routine. But yes, the investigations look at your main factors. We look at the sperm quality, so it's not just the count. That's the percentage of normal ones, and how they move is very important, because they've got to get through the egg wall, and even though there's millions of them, there's one got to do it. So we look at sperm quality. That's a high priority. We can't assess egg quality because unless we actually do IVF. So obviously we might look at factors that could affect egg quality. So that would be, again, focus on lifestyle, depending. There may be nothing to focus on there or a lot. And we look at the cavity of the uterus by special ultrasound or even an MRI, or even going further with a laparoscopy. And a hysteroscopy, it's called, where we look up inside from down below through the cervix. We look at the lining, we sample it.
Yeah.
All right. And again, it depends how much problem there's been. So you might start off the journey with a semen test to be done, the special ultrasound with dye studies inside the uterus to check its shape, to pick up if there's any polyps there that's been missed on standard scanning, and routine blood tests, which could include diabetes, you know, the HbA1c, but the diabetes screening. And we always check the thyroid as well. All right.
Yeah.
So there's just that general screening, which often takes you down a specific path. Absolutely.
That's
so,
right.
And then the background is age. We do the egg reserve blood test.
Yep.
That's hard to interpret. There's a little bit of discrepancy and debate in the scientific world about the relevance of it and how we interpret it. Generally, it's felt if the egg reserve is low, that can be a factor with fertility related to age, or always related to age. And that lower egg reserve is sometimes associated with eggs that aren't so good as well. Okay. So age keeps bobbing up as being one of our major problems. I mean, the average age of my patients in fertility practice is 39.9. I mean, that's average, which means a lot will be well in their 40s. And that's something we can't change. People are always trying to, but we can't manipulate that successfully at this point.
Yeah, that's right. So, Dr. Astill, you mentioned quite a lot about that component of diet and lifestyle to try to improve and optimize the overall egg health. What about if a patient already did the egg collections, like for IVF treatment? Is there anything that women can do to manipulate the endometrium or the lining to actually enhance the success rate of the embryo transfer?
In terms of manipulation, that's difficult. We can do some manipulation, but lifestyle is still important because of the indirect, almost direct impact on the immune system, because that's part of implantation. It's so complex. And the microbiome, we believe, is important. Some IVF regimes use antibiotics as a routine, but there'd be certain objections to that, of just using antibiotics as a matter of course. And you've got to be careful if you take vaginal or cervical swab tests to make your decisions on that, because the microbiome inside the uterus can be very different. So we can sample the lining and we can send it off for testing. It's fairly expensive to look at the balance and the ratios of the different bacteria, and that may have some relevance. But at the moment, we send that overseas because we also test on how the hormone receptors are running, whether they're on schedule. Remember, we got this short window for everything to be right. The lining has to be pretty well as it should be at the time the embryo is wanting to interact with it. So we can assess the lining. I think lifestyle is still important, and I think it's very important, but I think it's still indirect to some degree, because you're still back at the phase probably of the sperm, back at the phase of the egg quality rather than the implantation phase at this stage. But it's really hard to study the ongoing research. But we're not good at manipulating it. Of all the things that are being tried now, probably platelet-rich plasma, or PRP, is being used more often, because that stimulates all the processes mentioned before, the stem cell production, the inflammatory changes, the blood flow increase. the immune changes. It even affects the microbiome somewhat in a positive way. So people are looking at flushing the lining with platelet-rich plasma 2 days before they transfer, but not as a routine. It would be in people who are having recurrent problems.
Yeah.
Someone would need to talk to their clinician if they're in that situation and get their opinion.
Yeah, 100%.
Yeah.
So, Dr. Astill, my last question to you is, what would be your advice to our audience today who struggle with embryo transfer or still, having, for example, a quality issue, going through IVF treatment? What would be your biggest advice for this group of women?
Well, I think the individual couple has to, or it has to look at what they can do and to understand what the clinicians are doing. So what they can do, come back to that fitness, general health, the nutritional health, weight, cigarettes, alcohol, etc., keeping that to a minimum, the alcohol or nil, not smoking because it's so toxic. So they have to look at their contributions, then discuss with a clinician what possible things you could do. They're called add-ons or adjuvants that might help. And the tougher it gets, the more implantation failures, the more desperate the couple feel, the more desperate the doctor feels, the clinic feels. So it's very easy to slip into trying all sorts of things that are uncertain. And so it's got to be a joint discussion, and you've always got to look at, are these things definitely helpful? Is there any other option? What are the costs? Is there any side effects or complications from what I'm doing that might be an issue? So it has to be a good communication. If you start doing things outside of the standard lifestyle and nutritional supplementation, vitamins and antioxidants. As I said, we're not too sure, even with the antioxidants, with some of them, vitamin E, CoQ10 is a common one. How much does it really help? I think as long as we can say it does no harm and the patient has a pretty good slant on it, then I think it's fine to use those. But once you start branching out because you're becoming frustrated, you need to just be sure there's nothing negative about what you're doing.
Thank you so much for sharing
Catherine.
Your experience and insight for all of us here today. So Dr. Astill, could you please tell us, for our audience, if they're interested in working with you, where can they find you?
Through City Fertility, who are scattered down the East Coast and now in Perth. So really through City Fertility or websites, of course.
No worries at all. And I'll attach all your information down our video. So thank you so much, everyone, for watching. And thank you, Dr. Astill, for joining us. We'll see you in our next video. Bye for now.
Thanks, Catherine.